Welcome to the weekly Neurology Deep Dive, produced by America Vanini. Today, we're really getting into the neurological side of drug misuse, using a great review from Neural. It's by Howard, Holmes, and Dargan, published in 2025. Just a quick reminder, this deep dive is purely educational. No commercial goals here, it's really just a summary. We definitely recommend you read the full paper for all the details. Our aim today: to give you, our fellow neurologists, the key knowledge for spotting acute toxicity early and understanding those longer-term neurological effects of drug use disorder. It's a major issue, especially, hitting young people disproportionately hard. So for those short on time, here's the quick practical takeaway from the paper. Drug misuse. It's a global health crisis, big neurological impact, acute and chronic. Things are changing fast with new psychoactive substances popping up, making assessment tricky. Think polydrug use, variable drug content, key things neurologists see. Trauma, infections, hypoxic ischemic brain injury, seizures, toxic leukoencephalopathy, stroke is a really big one, crack and cocaine. They're the top drug-related causes, often tied to high blood pressure and vasculopathy. And don't forget long-term stuff. Cognitive issues, movement disorders, and that myeloneuropathy, particularly with nitrous oxide messing with B12. Spotting these patterns early, absolutely vital in our clinics.
Absolutely. And this paper really drives home how complex and frankly evolving this challenge is for us in neurology. It goes way beyond just the immediate, obvious acute stuff. The review highlights not just the sheer scale of substance use globally, but also this relentless waves of new psychoactive substances. It's not a fixed problem at all. It's constantly shifting, demanding we stay updated.
Yeah, those initial points really set the stage. Let's unpack that scale first. The global burden of drug use disorder. What are the key numbers from the United Nations Office of Drugs and Crime we should have in mind?
The figures are pretty sobering. So back in 2021, the UNODC reported around 296 million people worldwide. That's about 6% of folks aged 15 to 64 use a drug in the past year. Digging deeper, you've got roughly 36 million using amphetamines, maybe 22 million on cocaine, and about 20 million using ecstasy-type drugs. Critically, opioids are still causing the most severe harm. Around 60 million people were involved in non-medical opioid use, and of those, about 31.5 million used opiates, mostly heroin. The World Drug Report points out that drug use disorders cost about 18 million years of healthy life, mostly due to opioids. And this global picture, well, it hits close to home, too. In the U.S., overdose deaths hit something like 110,360 in March 2022. Fentanyl is a huge driver there. And in England, Wales, 2021 saw nearly 4,900 drug poisoning deaths. That's about 84 deaths per million people. Around 46% involved in opiate, about 17% cocaine. And what's really concerning is the higher use in young people, 16 to 24-year-olds. About 18% reported using some drug.
Those numbers are just staggering. But it's not just the volume, right? It's the pace of change. You mentioned these new psychoactive substances. How are they reshaping the clinical challenges for us?
Oh, definitely. The clinical picture is, constantly morphing.
Yeah.
By November 2023, the UNODC already knew of about 1,230 of these new psychoactive substances. The tricky part is they often mimic the classics: cannabis, cocaine, heroin, LSD, amphetamines. Most are stimulants. Then you have synthetic cannabinoid receptor agonists, classic hallucinogens. And lately we're seeing more synthetic opioids and novel benzodiazepines too. Adverse effects, they're all over the map. Seizures, agitation, aggression, acute psychosis, and definitely potential for dependence. A good example they mentioned is hexahydrocannabinol. It's a semi-synthetic cannabinoid, sort of pitched as a legal alternative to delta-9 THC. This constant innovation means we're often a step behind clinically.
Okay, so faced with this shifting landscape, what are the main hurdles in clinical assessment? The paper digs into this. What difficulties should we really be focusing on in practice?
Right, this is where it gets really tough day to day. First off, patients rarely use just one substance. Polydrug use, often with alcohol, is the norm. Makes it hard to pin down what's causing what. Second, the drugs themselves act differently based on dose, how they're taken oral, nasal, inhaled, injected, you name it. Plus, co-used drugs and the patient's own health background change things too. Third, illicit drugs are just inconsistent. Potency varies wildly, and they're often cut with other things. Fentanyl and other drugs, xylazine with opioids, levamisole and cocaine. Each adds its own layer of toxicity. And finally, standard lab tests. They have real limits. They show recent use, yeah, but not how much or how often. And many common substances, alcohol, synthetic cannabinoids, cathinones, even fentanyl, LSD, they just don't show up on routine screens, so you can miss a lot.
Sounds like navigating a minefield, especially under pressure. So when a patient does present acutely, the paper gives us these intoxication syndromes. Can we walk through the key features? Recognizing these seems crucial up front.
Absolutely. Knowing these patterns helps sort things out fast. The paper lays out three main ones. First, the sympathomimetic type. Think hyperalert, agitated, maybe delirious, big pupils, hallucinations, paranoia, seizures. Systemically high temp, fast heart rate, fast breathing, high blood pressure, sweating, causes. Usually amphetamines, cocaine, cathinones, ephedrine. But also, importantly, withdrawal from things like opioids or benzos can look like this too.
Okay, that's one. What's next?
Second, the hallucinogenic syndrome. This is more about altered perception, hallucinations, feeling disconnected, senses mixing up, maybe agitation, nystagmus, delirium. Systemically, temp, heart rate, breathing are often up. Blood pressure could be high or normal. This is your designer: amphetamines, ketamine, LSD, psilocybin, PCP, mescaline.
Got it. And the third?
Third is the inhibitory syndrome, opposite end of the spectrum. Sedation, pinpoint pupils, confusion, stupor, even coma. Systemically, everything's usually down or normal temp, heart rate, breathing, blood pressure. This is classic for opioids, fentanyl, heroin, morphine, methadone, oxycodone, but also benzodiazepines and barbiturates fit here. Knowing these helps frame that initial assessment.
Makes sense. But the drug effects aren't the whole story, are they? The paper talks about secondary issues like trauma and infections being major neurological concerns too.
They absolutely are. Trauma is common: brain, spinal cord, nerve injuries, often from falls, seizures, accidents, or violence when someone's intoxicated or impaired. You can see skull fractures, diffuse accidental injury, contusions, various bleeds, subdural, extradural, subarachnoid, intracerebral, the works. Infections are a huge risk, too, especially for IV drug users.
Yeah.
Endocarditis leading to stroke from septic emboli, skin infections spreading to bone, causing osteomyelitis, or even nasty things like tetanus, botulism, anthrax from skin popping. HIV is risk, of course.
Yeah.
And heroin specifically gets linked to cerebral abscesses. So yeah, lots of indirect neurological damage.
And the paper flags a specific type of hypoxic ischemic brain injury, HIBI, tied to opiate overdose. What should we look for there, particularly on imaging?
Right, this HEB pattern is often seen when someone isn't found for hours after an opiate overdose. They had prolonged, severe lack of oxygen, often with acidosis and low blood pressure. On MRI, the key finding is often extensive damage to the cortical and subcortical white matter. Interestingly, this can look different from the typical deep gray matter changes you might see in other kinds of hypoxic ischemic events. It's a subtle but potentially important distinction in this context.
Okay, useful clue. Now, many drugs mess with brain excitability directly. Let's talk seizures. The paper notes they're a direct complication for most drug classes.
Indeed, seizures are common, especially with withdrawal from sedatives or barbiturates. That sudden loss of inhibition can cause hyperexcitability. Also, acute intoxication with stimulants like amphetamines, MDMA, or those synthetic cannabinoids often triggers them. But remember, seizures can also be secondary, a result of trauma, a central nervous system infection, or even a stroke caused by drug use. So important to consider both direct and indirect causes.
Moving into the longer-term effects, toxic leukoencephalopathy sounds particularly nasty, especially linked to heroin. Can you describe that, and what's the characteristic MRI picture?
Yes, toxic leukoencephalopathy is a really severe one. It's most famously linked to inhaling heroin vapor, chasing the dragon, but also seen with injection or snorting over time. Clinically, it tends to creep up. Starts with behavior changes, maybe ataxia, slurred speech, then progresses to restlessness, motor problems, pyramidal and extrapyramidal, eventually profound encephalopathy, mutism, incontinence. Acute forms can even cause coma, respiratory failure. Chronic cases. Prognosis is generally poor stupor, slowed movement, lack of motivation, apraxia, language problems. The MRI findings are key. You see this diffuse white matter hyperintensity on T2 and flare sequences. It often favors the back of the brain, posterior parenchyma, posterior internal capsule, cerebellum. With IV or inhaled heroin, it might look more symmetric, confluent, hitting frontoparietal white matter, centrum semioval, internal capsule. Now, pathologically, it's interesting. It's a spongiform change, vacuoles and oligodendrocytes in the myelin sheath itself. But the axons, usually spared, not really a primary demyelination. That helps differentiate it. And it's not just heroin. Other opioids, crack cocaine, amphetamines, ecstasy, psilocybin, even inhalants like toluene or carbon monoxide can cause it. Oh, and cocaine-related leukoencephalopathy might actually be due to levamisole contamination, can sometimes mimic things like tumefactive MS or ADIM. Really tricky.
Wow, that's a devastating picture. It really underscores the potential for progressive damage. Let's switch gears to stroke. What's the biggest drug-related culprit there, and what are the mechanisms involved? That seems critical for neurologists.
Hands down, the most important cause is crack and cocaine. About half the ischemic strokes linked to it hit the middle cerebral artery territory, but you can see anterior spinal artery occlusion too. Chronic users. They often have these diffuse, asymptomatic white matter changes on scans already. The mechanisms, it's a whole list. Acute and chronic high blood pressure causing hemodynamic shifts, vasospasm, actual atherosclerosis in large vessels, dissections in neck or brain arteries. Cocaine can directly activate platelets, form clots, and it's directly toxic to blood vessels, causing a kind of small vessel angiitis, but not typically necrotizing. It's also linked to aneurysms formation, rupture, even delayed problems after rupture. Hemorrhagic stroke, particularly common with snorting, IV use, or crack smoking, often due to sudden severe hypertension, vasculitis, RCVS, or rupture of a pre-existing aneurysm or AVM. Can trigger PRES too. The sheer number of ways cocaine can cause a stroke as well is why we have to ask about it in seemingly any stroke case.
Absolutely essential point. Are there other key substances we need to consider for stroke risk?
Definitely. With amphetamines, stroke often happens right during or after use, but sometimes weeks or months later. Hemorrhage is actually more common than ischemic stroke here. Again, think severe hypertension, aneurysms, vasculitis, RCVS, and PRES can happen. Amphetamines also seem to have a direct toxic effect on vessels, sometimes called speed arteritis. Looks a bit like polyarteritis nodosa, can cause delayed infarcts. For heroin and other opioids, stroke is mainly tied to IV use complications. Infective endocarditis from dirty needles, septic emboli, mycotic aneurysm rupture. Also, adulterants mixed in, like talc or cornstarch, can embolize or cause a hypersensitivity angiitis. Even cannabis and synthetic cannabinoids aren't harmless. They bump up stroke risk through things like arrhythmias, low blood pressure, vasospasm, platelet issues. Can also cause RCVS. And finally, some hallucinogens, especially phencycline or PCP, are linked to hemorrhagic stroke.
So the takeaway is really the wide range of substances and mechanisms leading to stroke. Now, thinking beyond stroke, cognitive impairment is another major long-term issue. What causes it, and are there specific syndromes we should know?
Yeah. Cognitive problems can arise from lots of things in this context. Repeated head trauma, strokes, obviously, that hypoxic ischemic injury we talked about, or just heavy alcohol use alongside the drugs. There's a specific acute thing called the opioid amnestic syndrome. Patients present with sudden amnesia, disorientation, sometimes unresponsiveness, often linked to fentanyl, maybe transdermal patches, or as an adulterant. It's got a fancy name, cerebellar hippocampal, and basal nuclei transient edema with restricted diffusion, or Chancher syndrome. MRI shows restricted diffusion in basal ganglia and hippocampi, sometimes cerebellar swelling, even hemorrhage. Prognosis varies quite a bit. Beyond that acute syndrome, long-term use of opioids, cannabis, especially synthetics, dexamphetamine, cocaine, all are linked to broader neuropsychological deficits. Multiple domains affected. Chronic cocaine use, for instance, tends to hit attention, working memory, episodic and prospective memory, executive function. It can get worse over time, but the good news is it might improve if use is reduced or stopped.
And what about movement disorders? We often see those. What patterns should we be looking out for?
Several distinct patterns pop up. Chronic amphetamine, methamphetamine, or cathinone users might show puntering that purposeless, repetitive, stereotype behavior, like obsessively sorting things. Cocaine, amphetamines, they can cause cophics, vocal and motor, tremor, chorea, akathisia, even acute dystonic reactions, usually head and neck or jaw movements, sometimes called crack dancing with cocaine. Then there's severe Parkinsonism from MPTP, that nasty meperidine analog. And an interesting one is cot. If it has high manganese levels, it can cause manganese deposition, leading to an encephalopathy. Presents as severe Parkinsonism, sometimes looking like progressive supranuclear palsy, with characteristic bright spots in the basal ganglia on T1 MRI.
Fascinating how diverse the effects are. And they don't stop at the brain, right? The spinal cord and peripheral nerves can take a hit too. Let's talk about myeloneuropathy, especially with nitrous oxide and other neuromuscular problems.
Right, the neuromuscular system is definitely vulnerable. Nitrous oxide, or laughing gas, is a big one, especially as it's so common among young adults in the UK, third most used drug in that group. The mechanism is key. It messes up vitamin B12. It oxidizes cobalamin, disrupting B12-dependent enzymes needed for myelin. So clinically, it looks just like subacute combined degeneration of the cord. Yet spinal cord, brain, and peripheral nerve damage can be axonal, demyelinating, or mixed neuropathy. The classic MRI finding is that T2 hyperintensity in the back and sides of the cervical and thoracic cord, the inverted V sign. Really important point. Serum B12 levels are often normal. You need functional tests, methylmalonic acid, or homocysteine to clinch the diagnosis. Treatment is B12 replacement, but critically, the person has to stop using the nitrous oxide. Crucial diagnostic point about the functional B12 testing. What other neuromuscular issues come up? Well, other inhalants, toluene, glue, paint thinners, gasoline, acetone, and heroin too, can directly damage spinal cord white matter, sometimes as part of that toxic leukoencephalopathy picture. Then there are peripheral nerve issues. If someone's unconscious for a long time after an opiate overdose, they can get compression neuropathies, brachial plexus, peroneal, ulnar, sciatic nerves, just from pressure and lack of blood flow. Glue sniffers can get a severe axonal polyneuropathy from N-hexane toxicity. Heroin use is also linked to plexopathies, brachial or lumbosacral, and distal neuropathies. And finally, rhabdomyolysis, muscle breakdown with myoglobinuria, potentially leading to kidney failure, DIC, liver failure, can be direct toxicity from heroin, meth, cocaine, PCP, or it can be secondary to compartment syndrome, trauma, low blood pressure, fever, being muscle crush injuries. Even repeated intramuscular injections can cause local muscle damage and weakness. So a really broad range of potential neuromuscular complications.
Okay, so let's try to summarize the key practical points again for everyone listening. Drug misuse presents this really complex challenge in neurology. Spotting acute toxicity early is vital, yes, but we also have to grasp the sheer variety and potential severity of the long-term neurological damage. Remember how tricky assessment is polydrug use, inconsistent drug content, adulterants are common. Keep a high index of suspicion for trauma, infections, HIV, seizures, and that toxic leukoencephalopathy picture. We really emphasize crack cocaine as major stroke culprits. And we covered cognitive decline, movement disorders, and that specific nitrous oxide myeloneuropathy tied to B12 disruption. These are all absolutely critical things to keep in mind in your daily practice when you see these patients.
Exactly. And connecting it back, these neurological consequences aren't just diverse, they hit young people particularly hard, which makes timely recognition and intervention so important. Our job as neurologists goes beyond just treating symptoms. It's about digging for the underlying cause, recognizing these specific injury patterns linked to different substances, which, as we've discussed, keep changing. Which really leads to a crucial question, doesn't it? With new psychoactive substances emerging so fast and their effects being so varied, how do we in clinical practice adapt effectively? How do we ensure we're diagnosing and intervening promptly when our usual tools might not always keep up?
That's a great point to ponder. And that brings us to the end of this deep dive into the neurological aspects of drug misuse. Thanks so much for joining us for the weekly Neurology Deep Dive with Amer Gavanini. As always, we strongly recommend checking out the original paper for more depth. And maybe a final thought to leave you with. How might neuroimaging and maybe biomarker research evolve to help us stay ahead of this constantly shifting landscape of illicit substances? Could they offer new pathways for earlier diagnosis and perhaps more tailored treatments down the line?